Welcome to the Functional Neurologic Disorders Society podcast. I'm your host, Erica Cotton, coming to you from Chicago, Illinois, with a special thanks to Michael Romeo, our production engineer, coming to us from Australia, and our content curator, Ingrid Hertzauer, from the UK. My guest this week is Dr. Beatrice Garcin, who is a neurologist at Avicenne Hospital and Sorbonne, Paris, Nord University. We cover a range of topics, including TMS and FND, neurologic comorbidities in FND, positive signs and rule-in signs for FND, and FND practice specific to France and French culture. This was such an enjoyable and informative conversation, and I hope you all enjoy it. Oh, Beatrice, thank you so much for joining me today. I really am looking forward to this conversation. Let's start with your academic background, how you got into the field of FND, the career path you're on, all of those fun background items that we typically don't talk about or hear as much.
Erica, thank you. I'm really happy to be here today. So I'm a neurologist, and I firstly trained in general neurology, but also in movement disorders and in dementia and cognition. I was really more into cognition for a long time. I did a PhD on frontal lobe functions, so it was a bit far from FND. And in the end, I started to be interested in FND thanks to a French neurophysiologist, so thanks to a colleague of mine who I met in 2008 during my residency. She was involved in neurophysiology exploration, and she used TMS to perform motor evoked potentials. And there was something really positive and efficient in the way she approached patients. So that's how I started to be interested in FND, and then I wanted to study what she was doing. So I did a first study on the efficacy of TMS, and I started being involved with patients. And then you know how it is when you start to be involved with FND patients, because neurologists at this time and still now are not really interested into FND. I started to see more and more patients. And I realized it was useful, so I started to be really interested in the topic. So that's how it started. It was a long time ago, and then progressively, this activity became more and more important. And now I'm doing FND clinic most of the time. I would say at least half of my clinical time.
That's wonderful. How much time do you spend on research versus clinical? Do you consider yourself more of a clinician with part-time research, more of a researcher? Or are you, as one of my mentors says, 50-50, which really just means 100-100?
That's a good question. I don't know if I can say 50-50. I guess I spend more time on the clinical work, but my clinical work has always some link with research, because when I see patients, I always think about what kind of research I could do to understand better or to treat them better. So I would say maybe 60% clinical work and 40% research.
That's wonderful.
There is also some teaching.
All of the other academic demands, right? Oh, that's wonderful. Yeah. Oh, it's so great. So great to have people in FND clinical work, let alone who are interested then in contributing to the research and answering those questions. Yeah, that's awesome. Okay. You already started to pique my interest around some of the research that you've been doing. And before we dig more into some of the TMS aspects, I'm just wondering your views about the different subtypes, whether you consider yourself more of a lumper versus splitter. Is there separate entities of FND? Do you see more overlap? Do you view it as a spectrum? Just, what are your thoughts?
That's also a difficult question. I would say I'm more a lumper, because there is a huge clinical overlap between different subtypes of FND. there's nothing new in this. I mean, patients with motor FND have 80% of patients with motor FND have cognitive complaint. A lot of patients with motor FND also have functional seizures. And I think it makes more sense to defend the lumping view, notably if you want to study pathophysiology or phenomenology. And we did a study recently where we showed that 80% of the patients who have functional dissociative seizure also have clinical signs of motor or sensory FND, even when they don't have any complaint about it. So that's
Can you
really
tell us more about how that? Can you tell our listeners more about how you started? How did you even recognize that? How did you pick up on that? And then how you kind of executed that? It's such an interesting but wonderful thing to have done.
It started from a discussion with a colleague who is an epileptologist, and we were talking about functional seizures. And I started saying, yeah, but if you examine them, you can find signs that, positive sign for FND. And she said, but I never do this kind of examination. So for me, it was something obvious. But when I discussed with her, I realized that it's not obvious for epileptologists. So that's how I decided to start the study. I included all patients who was referred for functional seizure. I mean, for seizures that could be functional dissociative seizures. And it was quite straightforward. And I believe the most interesting result is for epileptologists who, don't really have the experience of motor or sensory FND because they don't know how to examine patients in this sense. And it can, really make it easier to diagnose functional dissociative seizure if the clinical examination goes in this direction.
Additional supportive features. I think one of my prior conversations, similarly with David Perez, was moving the field away from diagnostic rule out to rule in, and in addition to having the gold standard for having a typical episode recorded without EEG correlate with on video and EEG. If there's additional rule in signs, that I think just adds further diagnostic clarity and rigor to the diagnosis. Which specific signs did you look for that you feel like your epileptologist colleagues weren't?
You mean which clinical signs are more useful in this situation? That's also a good question because it's the sign I usually use, but maybe some other colleagues who work in the FND field will use other clinical signs. So I included my personal best checklist. Yeah, exactly. But I think the most useful signs were the splitting in the midline sensory sign.
The list that you have, and we'll post a link for our listeners to this wonderful article. There were discussions of sort of the validated rule-in signs from walking with like hesitant or cautious walking, knee buckling, from motor perspective, like a collapsing or a give way weakness, the chair test, Hoover sign, drifting without pronation, or sensory, like you said, the midline splitting, or like a systemic failure during sensory testing, or like the splitting with vibration was another one, or like ocular motor complaints, like effortful eye movements, expressions, which are all sort of positive clinical signs that, I don't know if a lot of epileptologists would say I don't necessarily see that in their exam notes. Like they come into the MU, they have one of their typical episodes, and this is what the diagnosis is.
Yeah, but it was really interesting to do this study because even myself working in the FND clinic, I was not really used to assess patients with seizure in this way, and I was sometimes really surprised to find all of these signs when patients were coming only for seizures. So
Yeah.
I mean,
Which, if you of all people are surprised, then gosh, how much are we missing with characterizing these patients? Because I feel like I don't know how it is in your clinic, but in my clinic and a lot of the clinics with my colleagues that I've spoken to in the US, people get split. They get sent to either epilepsy or movement disorders, right? If they're shaking, then they go to movement disorders. If they're losing consciousness or look like they're having these episodes, then they go to epilepsy. And they kind of get routed down one road and then kind of stay in that specialty domain. And I think you're
yeah,
100% right in raising some really interesting questions that actually there's more, especially from a positive sign diagnosis, way more overlap in these conditions and presentations than we are probably even assessing for.
yeah, I think that's an important point that you're raising, because it's really one of the interesting aspects of creating FND units is that you can have a more general view of all of these patients, whereas until now they are either sent in the epileptologist field or in the epilepsy department or in the movement disorders department, and that's probably why we have such a splitted view of FND. It's because they arrive from two different fields, movement disorders or epileptology. And that's, I mean, I have to think that's one of the reasons why most studies really included either functional dissociative seizures or motor FND, and not all kinds of FND subtypes. So I believe that lumping all FND subtypes is a good point, but on the other hand, it's not that simple, because I'm not sure that the mechanisms are exactly the same in dissociative seizures, where dissociation seems to be really a key mechanism, and in functional motor disorders, where attention and beliefs are maybe more involved. And also for randomized control trials, it's really difficult to include all types of FND, because then how do you assess the outcome if you include both seizures and motor disorders? And also the main treatments are not the same. I mean, treatments for functional motor disorders involve physiotherapy, whereas treatments of functional dissociative seizures involves more psychotherapy. So yeah, I think for some reasons, for some kind of research, it's interesting to lump those patients, but for some other aspects, we still need to separate them. Right. So it's not, I mean, not one answer to this question.
Yes, it's not either or, it's both and, more than likely. What I really love about this study is, ideally, if you can then start to build awareness of these positive clinical signs, even in dissociative seizures, then can we look at it more consistently, more clinically consistently, document this. But then also that might point to more of a shared mechanism, right? There's these core features of FND that create these systemic body-based weaknesses or brain-body connection challenges that are just general or core foundational to FND, with possibly these superimposed subtype specialties of additional ways that brain-body goes awry in those specific subtypes, especially if they're more pure in their subtypality, which we'll see. So I really appreciate this work. I think it's wonderful, and we will definitely post a link to it for our listeners, and highly recommend giving that a read. One other way that, or an additional way, where I think there's been some pretty big splitting, at least here in the US, is between neurology and psychiatry, or neurology and psychology for FND. And in another way, you've kind of bridged, I don't know if you intend to be a bridging modality across neurology between neurology and more traditionally psychiatry, because here in my practice setting, the TMS interventions are done by our psychiatrists, right?
Oh, really?
Yeah, not our neurologist. And that's a very separate thing. Like our neurologist would not, I don't know how it is at other institutions, would just, nope, that's a psychiatry thing for psychiatric phenomenon. So I'm wondering how TMS is regarded where you are, who performs it, how common is it for psychiatric use with FND? It's just another interesting ways that you're bridging and using sort of multimodal.
Yeah, so the TMS for FND is something really particular we're doing here in France. I don't think it's really recognized anywhere else. Even in France, it's not really, I mean, there is still some discussion with health insurance. But it's very different from the TMS that is usually recognized for psychiatric disease such as depression, because we don't really expect any neuromodulation in this treatment here. It really started by chance, because this doctor I talked about, Dr. Mesrati, noticed that when she was performing motor evoked potentials to patients to assess, the motor motor pathways of patients with weakness or movement disorders. She noticed that so when you do motor evoked potentials, you use TMS to induce a movement, and then you record the action potential. And she noticed when she was doing this that some patients were improved after the examination. So she started to use it, but it was really by chance because she noticed that motor evoked potential could improve patients. So after the exploration, she started to use TMS and apply it a bit more after the examination. And then she started to be really famous here in Paris. And I received like hundreds of patients. And I think that's really what makes the French experience. This woman who introduced the treatment, and we noticed that it worked. So then we did a few studies to understand the mechanism underlying the efficacy of TMS. But I really want to say that it's not the usual neuromodulatory TMS parameter. So here we use supra-threshold TMS, which means that each impulse induces a movement. And we only use a few impulses, like maybe 50. It's a very short treatment. And we believe that the efficacy relies on expectation and also on explanation, because during the motor evoked potentials, we show the patients that the potentials are normal, and we explain them that everything works properly. So this probably also helps the patient to understand the diagnosis, and then the movement, the normal movement induced by the TMS also helps patients to take to feel normal movements, and we believe that this is the main mechanism. So now Dr. Mesrati has seen more than 2,000 patients in maybe 15 years, and she's found an improvement in approximately 70% of the patients. So I believe it can help. It can help the patient improve and understand the disease. But we have some serious doubt about the long-term efficacy. Most patients have a relapse in the following months. And we really, really need a randomized controlled trial to show if TMS is really efficient in the long term. That's my plan. I've applied for funding last year, but didn't receive it. So I'm applying again. But I have a lot of questions about which control group will be the best. Should we use sham TMS? Should we use treatment as usual? Should we use TMS but under the motor threshold? And I'm still not sure about which control group we should use.
Such wonderful work. And I appreciate that explanation about it being different than a typical transcranial magnetic stimulation in terms of threshold, and potentially the role of a almost like biofeedback behavioral effect, right? Where a patient is seeing that their brain can in fact induce a motor response, and that the response is typical, the signal is normal, and reinforcing with a time-matched visual feedback of something accurate or positive that then creates that association. Yeah. Gosh, it's such a fascinating, brains and people are fascinating, right? It's just like trying to tease all this apart. I think in the US, we definitely use more biofeedback. Well, more biofeedback is more commonly used. Not at as major academic medical centers. I think like more traditional FND approaches like PT and OT and psychotherapy are the more first line interventions for FND here, with biofeedback being a supplementary approach in some cases that might not be FND specific, but is more just targeting attention or aspects of possibly motor processing. But the TMS aspect is not used from a motor perspective here in the US at all. And as I said, it sounds like in your practice, it's done by neurology, and in our specialties here, it's psychiatry, right? And it's for a psychiatric condition, which is a totally different paradigm, totally different intent, likely very different mechanisms.
Yeah, exactly. But we still lack a lot of evidence for this treatment. So, and the other problem I've noticed with the long-term follow-up is that some patients are really like they are cured with TMS, which is great. Everyone is happy, but then they relapse, and because they haven't really been engaged in treatment, it just suddenly came. I mean, they were really suddenly cured. Because of that, I think maybe in the long term it's not that good, because they believe that it can be cured like really easily, which is probably not really true in FND. So I don't know if my explanation is clear, but yeah, I'm not sure about the benefit of TMS in the long term. I think it can be really helpful to highlight the diagnosis, but patients need to understand that they have to be engaged in treatment
and follow up. And I wonder if it's not so much that TMS might not be as effective in the long term as is most interventions for FND might not have the same longevity once they stop, right? And there are some longitudinal studies, but again, usually it's impacted by low numbers or splitting of diagnostic categories or inconsistent interventions. And I think it's been a lot of people's clinical experience where during the treatment, they get a lot better. And then there's a group that responds, there's a small percentage that, respond really well and get all better and stay better for a long time. Or in the larger majority, make a fair amount of progress. And then once they stop treatment, things like maybe they maintain, but then there's maybe additional symptom flares in the setting of, additional life events or just passage of time. Then there's full relapses, right? Where it's just like, then they're right back to where they started, or, just really losing the treatment gains. And I'd be curious to see if TMS is actually different than other treatment modalities, long-term outcomes. And I don't know if we have that information yet. I don't know if we have that for all these other treatment modalities.
No, I don't think so. That's why we want to set up randomized controlled trials and follow up patients for at least 1 year, but maybe more.
Yeah. And especially for mixed populations, because I think there's some literature on, functional seizures and those outcomes. But again, those are narrow. I don't know if that reflects, people with multiple, mixed diagnostic pictures or certain risk factors. And if the risk factors are the same or different for TMS versus general outcomes in FND.
Here we use TMS only for motor functional motor disorders, because it's difficult to, I mean, the TMS we use really relies on showing the patients that the motor pathways are working properly and then demonstrating the normal movement. So I think there is not a lot of rationale to use TMS for functional seizures. I mean, TMS in the way we use it. There are other patterns of TMS that are currently studied in other groups. But so yeah, here we use it only for functional motor disorders. But when patients improve, they often improved also regarding pain and other symptoms.
Oh, that's wonderful. Additional benefit. I wonder that poses an interesting question for mixed populations as well, right? If someone is, or primary, right? If someone has primary functional motor symptoms and occasionally or very rarely will have a functional seizure, their persistent daily difficulty is their gait difficulty or walking difficulty or hand tremors. And once a month, they happen to have, a brief functional seizure episode. Would those individuals be excluded or qualify, do you think, for TMS?
No. I mean, we would include them if we don't have any doubt about epilepsy. And I think it can be also useful because sometimes TMS can induce a functional dissociative seizure. But if it induces a seizure, you can show the patient, how to manage the seizure using grounding techniques and explaining the patient what's happening. So for us, patients having a seizure is not an exclusion criteria, but we would propose TMS only to patients who mainly have motor symptoms as a primary presentation.
Yes. Yep, exactly. That makes complete sense. I'm glad that rarely occurring functional seizures is not exclusionary, because I just see so many patients who are mixed, overlapped. And along that line, I think there is bias is the wrong word. There's a difference, and this is where I think maybe splitting might be helpful in some cases, a lot of my colleagues just in clinical practice too say, well, functional seizures, you treat them with psychotherapy, they will get better and generally stay better and are slightly easier to treat in terms of psychotherapy. And you take this approach and you do this and it gets better for a lot of patients and generally stays a lot better. I think the general consensus around functional movements, especially if there's complex movements or multiple movements and layers of movement issues, that it can be harder to make the same amount of treatment gains and then harder to maintain and easier to fall back. So it might also not be that TMS is less effective in the long term, but the patient population of functional movements or the symptoms population that you're treating of functional movements is just harder. There might be something more intrinsically entrenched about the pathophysiology of functional movements than the dissociative mechanism of functional seizures. So it might not be that the treatment's not great. It's you're working with harder symptoms, which might also be the case.
Yeah, maybe. I don't know if there is any data showing that functional dissociative seizure has a better prognosis than functional motor disorders. Do you know that? I don't know.
Explicitly in the literature, I would say no. That would be a great study. Someone should do that. We should look at that actually, comparing outcome studies and qualities for functional seizures versus functional movements, just colloquially discussing among my colleagues. It's like, yeah, we can.
That's interesting because, I have the same feeling, but now that you're saying that, I don't remember seeing any publication about this.
Nope, I don't think so. And I think a big drawback of that is, and this is another avenue I think where functional movements are at a disadvantage, is for non-epileptic seizures, the outcome's easy. Like, how many seizure episodes did you have, right? The outcome is clearly, easily definable, consistent, even if a person's seizure semiology, non-epileptic seizure semiology is varied. It's like, did you have one or didn't you, right? There's a discrete way to measure it. But I think with functional movement disorders, it's so much harder given the variability and really tracking if symptoms got better. Like, it's really hard to, as you mentioned, even characterize what's present, classifying some form of severity, and then tracking improvement, especially if there's multiple symptoms, and then comparing multiple different types of symptoms that are different across patients. And then how are we characterizing change and improvement in symptoms? Is it, they went from 5 symptom categories of 5, level 5 severity to 2 symptom categories that are now at a level 2 severity, is that how we measure change? But we don't have clinical measures that classify functional movement severity in that way to reliably even track change. I mean, there's some, I think the existing literature's existing PT metrics, like walking scores and that kind of thing. But I think that's another challenge.
Yeah, but outcome measure is still a big issue, I think, in FND. I agree with what you say. It's more difficult in motor or other FND than functional seizures. We didn't talk about that, but there is also this big overlap with other somatic symptom disorders, notably chronic fatigue, nociplastic pain, fibromyalgia, bladder symptoms, and it's really difficult to assess the whole picture.
Right, the full range of body-related dysfunction that might be present. Yeah.
Yeah.
Yep. On that note, I want to be mindful of our time because I know I only have you for a limited bit. Thank you. We're trying to bring more of a cultural awareness aspect to FND and just how FND is regarded in other countries, how it's talked about, how it's known, barriers to care or diagnosis in other countries, or ways that other countries are like, hey, we've got this sorted out, and that other countries should adopt this model because it's working really well in other countries. Do you have any thoughts about that, especially given your practice location?
So I don't think we have sorted this out.
Rats, we can't just say.
No, I mean maybe soon. I hope we will find solutions. There is some. I'm not aware of how every health system works, but in France there is something. The health is really funded by the government. It's funded a lot. And there is a category of activities such as memory clinic, which are considered as, more time-consuming and less efficient in terms of economy and medical economy. So the Ministry of Health in France funds some specific activities such as memory clinics, pain clinics. And so I'm currently really trying to ask for funding for FND in the same way, because it's a clinical activity that is really time consuming if you want to make things properly. And I hope it will work, but at the moment we don't have any funding. So we are still struggling, because those patients are more time consuming, because they have long medical history, past traumatic history, because it takes more time to explain the diagnosis. It's more difficult to understand the diagnosis because there is no awareness about FND. So when you say you have FND, patients are like, what is it? So because of all of this, there are very, very few neurologists involved in FND currently in France. I'm probably one of the only one, really, and I'm receiving referrals from all of the country at the moment.
Well, thank goodness you're doing it. Gosh.
No, I'm not doing it. I cannot do
my
it.
Goodness, that is... I thought we were low on treatment providers here in the U.S., and you're pretty much it for all of France.
I mean, there are too many patients. I cannot see all of them, so it's really difficult. But in the past 3 or 4 years, there have been a bit of awareness, at least amongst neurologists and psychiatrists. So with a colleague of mine, Guillaume Carl Tout-le-Monde, we created the French FND network 4 years ago, or maybe 5 years ago. And we have 200 health professionals involved in this network. We also organize the meetings. We try to put some interest in the disease. But I think we have still a lot to do. For example, until now, FND is not part of the medical studies. So medical students never learn anything about FND.
That was my next question, was if they receive training in it. And it sounds like nope.
It's not in the program of the general medical studies before residency. I wrote the chapter, and it should arrive maybe in 2025.
It's wonderful.
But until now, it was not even in the medical program. So,
wow, that is great. You are making such a huge impact countrywide and training all of those new physicians. That's wonderful. Excellent work.
I'm trying to, but there's still a lot to do. And regarding differences between countries, I think in France we have a very good health insurance, so patients access health quite easily. But we have an issue with psychotherapy. For example, physiotherapy is reimbursed, speech therapy is reimbursed, but psychotherapy is not included in the care. It's not reimbursed, so it's a real
barrier
problem for patients. Yeah, I think it's a barrier for our patients, because they have to pay for psychotherapy, and most of the patients don't have enough resources to pay that.
Yeah, out of pocket, that's expensive. Yeah, they're similar. It sounds like the barriers are similar in terms of provider awareness, medical education, patient education across other specialties too. Like if neurologists don't know about it, then how will, ER doctors, or emergency room doctors or primary care doctors know about it? And I think maybe the reverse, slightly more true. It depends on the type of insurance. I think, in the US here, it depends, since we have such a decentralized medical system in terms of insurance and payers, it depends on which insurance you have and what they'll cover. And that largely dictates services. They can get, this insurance will cover 6 sessions of physical therapy, but this insurance will cover 24 sessions or indefinite physical therapy. And the same thing with mental health. Certain mental health carriers will cover psychotherapy and others won't cover it, or they'll carve it out and say only for this amount, which are challenges as well. But it's nice that the patients in France at least have more uniform access in certain ways, but similar issues in terms of training and awareness that you are leading a charge on, which is wonderful. Not only doing a ton of clinical work, but producing really great research and high quality research. So we'll link both of the interictal signs for FND and functional seizures, as well as 2 or 3 of the prior publications on TMS for FND. If we had more time, maybe we'll have you back on another panel discussion of outcome measurement in FND, because just how much work you've done with TMS and looking at symptom impact and symptom improvement, how we could actually be measuring symptom outcomes, I think is, we have so many bright people. I'm sure we can solve that problem some way. But love to pick your brain about that in the future. But thank you so much for your time. I want to be mindful of your time. I know we're coming up on an hour here. But this has just been such an enjoyable conversation, in hearing about what you do, the great work that you're doing. I am now such an advocate of yes, France, you can do it. Expand the provider network. Follow Beatrice. She's leading the charge, and gosh, what an impact you're having. It's such a delight to see. It's really wonderful. Physicians and providers treating functional seizures, we invite you to participate in a brief survey examining driving recommendations for patients with functional seizures. Developed by a dedicated study group, this survey seeks to capture the current opinions of physicians worldwide on this topic. Please take a moment to share your experience. A link to the 5-minute survey can be found in the show notes.